and the micro CT looked at all the bone, and the histology, these discs look just like an old person's degenerated disc, just by knocking out one transcription factor. So there's much more going on here than just the end-stage phenotype that we're going to reconstruct surgically. And the ability to intervene upstream and modulate these things could have a tremendous effect on these people. But it's not just enough to modulate it. You also need to be able to diagnose it, because by the time you see the x-ray of the degeneration, or then your office or the disc space collapse, now you're not only modulating, you also have to rebuild tissue from scratch. And that's much harder to do. So we need to identify these people early and intervene early and modulate it to prevent this from happening. And there's every reason to believe that's possible with the emerging data that we're learning from this. And so the net effect, so far what we think is small perturbations have a profound effect on the phenotype of the disc, and we now know there's probably corollaries to genetic predispositions, because some people say, oh, we have bad backs in our family, or some people's families are more prone to osteoarthritis. So what are the treatment options? Well, right now, in terms of what we're doing in orthopedics for joints, spine, or everything in the bone, there's a lot of excitement about cell therapies and protein therapies, and there's a big debate for what should we do. At some point, you're going to intervene with either protein that you inject, cells that you inject, or cells that you inject that are transfected to make protein, i.e. Stem cells that are transfected with a gene for BMP. Wherever you're going to intervene, there's a growing recognition you better intervene here, because the further you go, the more you start to destroy the actual tissue itself, and even if you stop the process, you're left with a suboptimal tissue structure. So we need to do early diagnosis and early intervention. Now, my personal bias would say the nucleus pulposus is probably, in my opinion, the most biologically inhospitable environment in the human body. It has no blood flow. All the nutrient transport is through diffusion mediated. It has a lower pH than most other parts of the body. And so basically, a nucleus pulposus cell is like this little guy in the spacesuit sitting on the moon. And these cells are specially adapted to survive in that environment. So what that means, in my view, is probably protein therapies are the way to go, because injecting stem cells or external cells into this environment is probably not going to be the first tissue in the history of humankind that we have stem cell therapy working well. It's really a real challenge. I'm not saying it's not possible, but probably protein therapies are going to be where we have the most success early on. And articular cartilage, in some ways, is similar for other reasons because of the hydrostatic pressures in there. So what do we have to support this? Well, I'm going to go through this part quickly to get to the nanotech stuff at the end, because everybody wants to hear. Well, one in vivo model I worked on was with a rabbit model for disc injury, where you then did needle punctures, injure the disc, and then did stem cell transplantations after injury. And so this is sort of the surgeries. And one key thing about this is if you don't have a good delivery mechanism, the only way to get the cells into the disc is to inject them. Well, this is going to show, this is a needle injection of a disc. And this isn't part of the talk, but this is a biomarker that we made with imaging for early diagnosis. This is the normal disc, and this is a disc 4 weeks after we stabbed it with a needle, which you'd have to do to inject the stem cell treatments. And we're getting very good now at pre-symptomatically having very high-resolution biomarkers and imaging for structural degeneration. So we can diagnose the disease early, but we don't yet have a way to intervene and treat it. And this is a whole separate topic of biomarkers. And this is an example, just like the biomarker, this is what a conventional MRI would show for the disc with response to stab injury. And this is what's emerging now with our ability with biomarkers. We have much better resolution. These color-coded maps correspond to T2 relaxation time, so we can actually visualize the tissue structure of the disc. So the technology is here now to non-invasively assess the structural integrity pre-degeneration, or to assess the integrity as it responds to a treatment therapy, but we don't yet have a treatment. So our aim is to get upstream, diagnose it early, intervene, and do something hopefully better than what we're doing now, which is end-stage reconstructions of degenerated joints. Because it's a lot easier to intervene up here than to start down here and try to climb your way up. And so right now we're collaborating with Ennio and Dr. Ferrari, and then at the Methodist Hospital is Dr. Weiner, myself, and Dr. Liu. And so for early diagnosis, Ennio's group has done a lot of work that he already went over with you guys with his protein chips. Now, he didn't spend a lot of time touting it. What I heard him talk, the first thing I think about is you can use these chips for diagnosis. Because we're already established there's a huge cellular cascade going on here, or if we can we haven't even characterized it yet. So first we need to get everybody and just figure out what exactly is going on in the proteomics of these patients, normal patients or disease patients. Once you figure that out, then we can think about how best to intervene. And we know this is significant because from our animal models and the human data I showed you, we know there's differences between the chemical milieux of these different people. And so at some point, if Ennio stands up and waves at me, it means I got in trouble, but I think I took out most of the slides that they made me take out before I came, but just in case, he's watching me closely. So With the silica chips, he told you about all of his ideas for them. But when I hear them from my perspective, what I want to do, these chips are basically molecular sieves. They're perfect for proteomics. Because what we can do now is, if we take the tissue out or we take out fluid from the joint, we can drop them onto his chips and do proteomics, which is the equivalent. I mean, first we had 2D gel electrophoresis, then mass spectroscopy. But what these chips can do in theory with the nanotechnology of protein sorting is provide high-resolution maps of what exactly is going on in this tissue. And that's what we need to do to get our handles around these diseases to intervene and do treatments for them. So that's everything that he's talked about. He has so many wonderful discoveries. This is the only thing that sticks in my mind. He's told me so much. That's all I know. This one slide. And the reason for this is biomarkers are key for all these diseases down the road. And if right now, our option for biomarkers is we go into the operating room, get the fluid out, have to put protease inhibitors on the fluid. Then that then has to go either for an ELISA assay, a specific ELISA assay where you already have to say ahead of time what you're looking for, and they're very costly. If you don't do an ELISA assay, there's other options, mass spectrometer and other things, but all these things are unwieldy, and they really make it difficult to translate the technology into the clinical environment. Because you're in the operating room, you're not going to get people who are going to take the time to collect those samples, put protease inhibitors into them. It's just too unwieldy. But if you have a little chip you can drop the fluid onto, and it's stabilized, and you do the proteomics, you're going to rapidly advance our ability to treat these diseases. First off, to characterize the diseases so we can even figure out what's the best way to treat them. And there's an example, and I'm not doing justice to what Ennio and his group have done, but I'm just what I think about it. Is these chips, because the pores are so small, the enzymes that degrade the proteins can't get into them. So these proteins are stable in these chips at room temperature for, I think, as long as he's tested them. So in the operating room, I can take some cerebrospinal fluid out, drop it on the chip, put it in an envelope or my back pocket or anywhere, and then they can analyze these down the road and get high-resolution proteomics, which is, so far from what I understand, better than, or at least equivalent to what we know with mass spectroscopy, without half of the rigmarole you have to do to maintain those samples. That's the kind of technology that we need to really translate these things into the clinical environment and affect quality of care for the patients. And the other option then is spinal cord injury, and I'll go quickly because I'm running out of time, but the holy grail, or one of them I think really for what we do in terms of spinal cord trauma, is to do something for these patients that have these devastating neurologic injuries. And right now, this is the American Spinal Cord Injury Center's classification chart. When somebody comes into the trauma bay, we classify their spinal cord injury based on nerve root level of function. And basically, this is a nerve root level is going from here to going to here. If you can preserve one level of function, you dramatically change that patient's life forever. If you go from C4 to C5, you have someone who's on a ventilator to someone who's not on a ventilator. You go from C5 to C6, you can work a wheelchair. C6 to C7, you can extend your arm. You can push yourself out of a chair. You can transfer from bed to chair to other areas. You can walk with crutches. So just preserving a little bit of an area, you'll change someone's life forever. So how do you do that? Well, the issue with spinal cord trauma is not just the blow to the spinal cord. After you bang the spinal cord, you get a tremendous secondary cascade of inflammatory markers and degeneration, which is called the secondary injury. So there's a lot of talk in the lay press about giving people with spinal cord trauma steroids. Well, that's just a big brute force attack to try to knock down all those cytokines. Some of those cytokines are probably important, so you don't want to get rid of all of them. And what's even more important is the temporal timing of when those things are released. And so the first step is to characterize it. It has not yet been well characterized, the distribution of these cytokines, the temporal distribution, which ones are good, which ones are bad, and how does that correlate with spinal cord injury. And then the next step is the glial scar. After you have this massive secondary injury, you then get a glial scar that forms, and that glial scar contains proteoglycans which inhibit the ability of axons to grow and regenerate. And Regeneron's got an oligodendrocyte stem cell trial. All these therapies are aimed at modulating the glial scar. So you need A, a way to characterize what's going on, and B, a way to deliver the treatment. And this is just a schematic diagram of, so far at least, what we think is going on with the secondary injury cascade. And this is probably 10 years from now, we'll look back at this and laugh, because this has nothing on it for graphs of time. This doesn't all happen at once. These are things that happen, it's intricately balanced, and if you can modulate this cascade, you modulate the secondary injury. If you modulate the secondary injury, you restore neurologic levels. There is well-reported in the literature for cervical spinal cords, there's a high incidence of people have an injury at one level, and they will then ascend and lose additional levels in the time post-injury because of the secondary cascade. I saw someone go from C7 to C2. They went from arms to not able to do anything below their chin just from secondary injury. If you can modulate that, you change people's lives. So now the nanotech. So the nanopore silicone enclosures for drug delivery is one thing we're actually working on doing right now. And this is important for fracture healing, fusion, delivery of therapies, and if you want to get really into a treatment of osteoporosis.